Thank you, John. Good morning to everybody. So to begin, I'm a surgeon. I'm not conflict of interest. And to begin my talk, I want to go back to the recommendation of St. Gallen of 2011. Here you see the paper reporting the recommendation of the panel. And you will see from my talk that little has changed as far as the recommendations are concerned. But we now have more evidence, some controversies, and another trial has started. According to the panel, isolated tumor cells and even metastasis up to 2 millimeters micrometastasis in a single sentinel node are not an indication for axillary dissection. In addition, the panel accepted the option of omitting axillary dissection for macrometastasis in the context of breast-conserving surgery and radiation for limited sentinel node involvement. But, however, the panel was very clear that this practice should not be extended more generally, for example, to patients undergoing mastectomy, to those who will receive, who don't receive whole breast radiation, and those receiving neoadjuvant therapy or with involvement of more than 2 nodes. But as you see, the recommendation, the panel's recommendation on micrometastasis were based on the results of the trial Z11. Since then, the results of the International Breast Cancer Study Group, the trial 2301, specifically on micrometastasis, has recently, very recently, Monday, was published on this data. So this trial was aimed to determine whether no axillary dissection was non-inferior to axillary dissection when we have only micrometastasis in the sentinel node. Here you can see the design of the study. Patient with tumor up to 5 centimeters scheduled for breast-conserving surgery or mastectomy. When the sentinel node is micrometastatic, we are randomized to receive axillary dissection or no further axillary treatment. We eventually managed to recruit 931 patients, so distributed in the 2 arms. You can see the characteristics of the patient. The great majority had tumor less than 3 centimeters, and the great majority had estrogen receptor status positive, well distributed in the 2 arms, as you can see here. And 9% of the patients receive mastectomy. And very interesting is also that in 19% they receive only intraoperative radiotherapy. And the majority receive some form of systemic therapy, so well distributed, equally distributed in the 2 arms. And as regard events, you can see that, again, we have a very low axillary event, only 1% in the no-AD arm and less than 1% in the AD arm. Here you can see disease-free survival is slightly better for the no-AD arm, but was not significant, but the criterion of non-inferiority was fulfilled, as you can see. And here you can see the overall survival that is very good. The 2 curves are completely identical. And after 5 years, we have an overall survival of 97%. So from this study, we can see a subgroup analysis. You can see that the other ratios favor, the most favor no-AD arm, and all other ratio favoring non-inferiority criteria. So from these results, we may conclude that not giving axillary dissection to patients not only with 1 sentinel node with macrometastasis, but with 1 or more micrometastasis had no adverse influence on disease-free survival and overall survival. So this study provides more further level 1 evidence in support of the St. Gallen recommendation of 2011 that axillary dissection should not be performed if the sentinel node contains only micrometastases. But what about no ID in patient schedule for mastectomy? Well, the trial 2301, only 9% in this trial were patients that received mastectomy, so this trial did not draw any conclusion for these subgroups. But I want to present you two retrospective studies, one from the European Institute of Oncology, in which no axillary dissection was performed in 90 patients undergoing mastectomy with sentinel node macrometastasis. And you can see that the majority of patients were premenopausal and 61% received nipple-sparing mastectomy. More than 50% had PT2 disease, and over half had luminal B molecular subtypes. Only 2.2% receive radiotherapy, and the majority receive some forms of systemic treatment. And up to now, we have only one axillary recurrence in this group with a median follow-up of 20 months. So again, we have a very low axillary recurrence and very low recurrences. Another important retrospective study, is that from the Memorial Sloan Kettering, who compared 210 patients who received mastectomy with 325 patients who received breast-conserving surgery. All the patients had early breast cancer with minimal sentinel node involvement. And after a median follow-up of 57 months, you can see that the disease-free survival and overall survival were very similar in the two groups. And so the authors concluded that early-stage breast cancer patients with minimal sentinel node disease experience excellent outcomes without AD, even if they undergo mastectomy. So we may conclude that it seems possible, therefore, that axillary dissection may also be abandoned in mastectomy patients with limited sentinel node involvement. Now I want to remind you of the results of the trial Z11. And here you can see the study. Patients were recruited, patients with T1, T2 tumor with minimal sentinel node involvement, 1 to 2 positive nodes, including macrometastasis, and patients were randomized to axillary dissection versus no further axillary treatment. All the patients underwent breast-conserving surgery and all were given whole breast irradiation and systemic treatment. And again, you can see the two curves that in overall survival, the two curves are undistinguishable, with a very good overall survival and a good disease-free survival after 6 years of follow-up. So the authors concluded that it was time to abandon AD in early breast cancer with a positive sentinel node, provided they receive systemic adjuvant treatment and whole breast radiation. So it doesn't work anymore. Okay, so can we accept the conclusion of Z11 and completely abandon axillary dissection with the limited sentinel node involvement? So there are a lot, I think that also a lot of you are not so confident in this because there are some criticism in the trial that are reported, and I want to show you. And these are that the trial closed recruiting only half of the projected number of patients recruited, and so might not have power to detect a small difference in outcomes between two groups. Then axillary recurrence rate is in the no-ID arm was double that in the AD arm. The criterion of non-inferiority was too lax. because 5-year survival in the no-AD arm assume not less than 75% of death in the AD arm. And I think the most important criticism is that not doing axillary dissection, no information of a possible additional axillary nodes that may change treatment is not obtained. But this criticism, I think, have been countered by Giuliano by emphasizing that we have no difference in 5 years disease-free survival between the two arms, emphasizing no difference in disease-free survival between the two arms, excellent, as you have seen before, overall survival and disease-free survival in the no-AD arm, and noting that, in fact, overall survival and disease-free survival was better in the no-AD arm, but was not significant. And particularly the low rate of axillary disease in the no-AD arm, considering that 70% in the AD arm had other additional positive nodes. And again, there are other data that indicate that complete axillary information almost never changes adjuvant treatment. So I personally feel that these counter-arguments are convincing, and what I want to say to you that this is the take-home message that for most patients with early breast cancer and clinically negative axilla, a positive node should not be further treated, even though the decision should continue to consider all the relevant factors, including patient's age, comorbidities, and also patient preference. But this data, I think, that raise another important and new question, whether we even need to perform sentinel node biopsy in very small tumor. To try to answer this question, we have started a new multicentric, non-inferiority randomized trial that is called SOUND, because it is an acronym of sentinel node versus observation after axillary ultrasound. Here you can see the design of the study. It's a very simple design. Patients with tumor up to 2 centimeters, any age, were recruited when the axilla was assessed as negative by ultrasound and were randomized to sentinel node biopsies versus observation. Well, let us consider what is the rationale of this trial. So we have seen that today sentinel node biopsy has lost much of its importance because we don't do anymore axillary dissection when the sentinel node is negative, when it is macrometastatic, and now not even when it is positive. And furthermore, advancing imaging technology can identify increasingly smaller axillary involvement and may be used for axillary staging. And finally, adjuvant treatment recommendation, as you have heard in these days, increasingly depend on primary tumor biology and not of axillary status. The primary endpoint of this trial is distant disease-free survival, and the secondary endpoints are axillary recurrences, disease-free survival, and overall survival, quality of life, and type of adjuvant treatment. Here you can see centers in Italy that are already involved in or about to join the trial, and also centers throughout the world that are expressed interest in this trial. So for the conclusion, I'm in time, I think. We can say that it's clear that sentinel node biopsy story is destined to run and run, but I think that in a few years' time we will be considering data on the option of no longer doing sentinel node biopsy. And in the meantime, I suggest change in accepting the option of omitting axillary dissection in recommending no axillary dissection as standard practice in patients with early breast cancer and limited sentinel node involvement. Thank you for your attention.